taking a look over the last year, what seemed to be the general buzz, the most important topics. I even included some of the other examples, and even went to the point of looking Circulation, Lancet, New England Journal of Medicine, and really that pinnacle of journalism, Endovascular Today, to see what I could come up with. And actually, when I did do that independently, I came up with an idea of topics that I was going to talk about. Covered versus bare metal stents, drug-eluting stents and balloons, percutaneous treatment, tibial occlusion, endovascular intervention after prior bypass, and then the new Wi-Fi system talking about how to better stratify lower extremity intervention. And then and only then did I actually look at the program, and I realized that Dr. Funaki already had the first one covered. Dr. Pena was already talking about the second. Dr. Adams, my colleague and partner, was talking about the third, and it appears Dr. Guillermo was talking about the fourth. Dr. Patel, I don't think, is talking about Wi-Fi, but actually I'm talking about that a little bit later today. So I had to go back to the drawing board and say, well, you know, maybe he asked me to talk about my particular interest and expertise, and what would that be? What do I know probably more about than anybody else in this room? Well, maybe growing food plots for wildlife management, but that might be a little off topic. Do-it-yourself patios, I bet I could beat all of you to the punch. And finally, advanced home brewing. This is the Brewmeister General right there. But I thought, well, you know, maybe that's not going to cut it either, because we're supposed to be talking about endovascular therapy. So I took a little bit of liberty with my title and said, probably talking about what's new in the clinical decision management of peripheral arterial disease, and get my talk out of the way, and we can really then focus on the good stuff. So in making decisions for patient care, it'd be very helpful to be able to accurately predict and not just guess the results of our treatment ahead of time. Our group at MUSC has previously published and talked to a great deal about our Markov decision analysis model that is individualized for individual patients. And before you all go to sleep, I do want to say that there actually is some relevance to that we've been able to, if you actually look at measurement of actual patient quality of life, there is some predictive value of this, although there's a lot to go. And in fact, we recently showed that when you look at, for example, predicting the mortality of open surgery and endovascular, that we weren't that far off. Although actually predicting in what was the actual primary patency at 2 years, turned out that we maybe overestimate a little bit what we're going to achieve with open surgery and maybe underestimate a little bit what we would achieve with endovascular therapy. So that seems to be a little bit the cruxes in terms of predicting what it is, what are the outcomes that we're going to come up with. And in fact, if you look at the outcome probabilities that we used, that it was kind of all over the place. A patency at 5 years, the minimum of 0.1% all the way up to 97% for open surgery, et cetera. So there are a couple of models, predictive models out there that are available to us right now. And in the VA system, we actually have the VASQUIP, and you can go online and choosing for vascular surgery, you can put in the particular demographic variables available for your patient, some of those things, and actually come up with a 30-day mortality estimate. And it's not too bad. It's really pretty good overall. It's based on 30,000 patients per year. It's updated every year in terms of what's available, but for the very high-risk patients, it tends to underestimate the mortality. And in fact, all it gives you is the mortality. Well, for the surgeons in the room, you also know that there's also the opportunity to use the American College of Surgeons Surgical Risk Calculator, and you can go online for that, put your patient data in, and you can actually also get surgical risk, and more than just mortality, you can also get all kinds of other things like cardiac complications, pneumonia risk, return to the operating room. But really, there isn't much of anything specifically talking about vascular outcomes. Now, there is another option available, and this is these are poor photographs from my iPhone, but you can actually go on, and there's an app for that. Going from the vascular surgery group in Northern New England, they have actually come up with some predictors that you can actually use. And looking for lower extremity, you put information: age, gender, diabetes, presence of COPD, congestive heart failure, cardiac stress test, statin use, critical limb ischemia, and you can then kind of come up and they'll give you a predictor and that has been validated and is based on tens of thousands of patients. But again, all it really tells you in this case is the in-hospital risk of major cardiac event, myocardial infarction and others. Again, not really telling you the outcomes that we're particularly interested in, that we're used to, such as patency and otherwise. So when we look specifically at revascularization outcomes, we actually went to look at our section, our region of the Vascular Quality Initiative, the Carolinas Vascular Quality Group, and headed actually by Dr. Hallett. And we look at all the patients that have been done in the Carolinas over the past couple of years, entered into this for peripheral vascular intervention, infrainguinal bypass, suprainguinal bypass. And you're not supposed to read this, but we were able to, using obviously complex computer regression models, come up with something that would be able to predict with some accuracy what was going to happen. And we put this initially on an Excel spreadsheet with the idea of perhaps bringing it forward into an iPhone or other phone app. And again, you put the information in and you can get, for example, for infrainguinal bypass, you can get major adverse limb event. LOAFS stands for loss of amputation-free survival, and you can actually use this to be able to compare for your particular patient what would happen if you treated them endovascularly versus open surgery with some predictive value. If you go back in and do what's called bootstrapping statistically to sort of see, well, how sensitive and specific it is, in fact, it's very disappointing. And it's disappointing that, in fact, that the so-called area under the curve, which you'd like to see right around 1.0, was in the poor range. Well, we took that and we thought, is there a way to make that better? And initially we thought, well, we only had a couple thousand patients with PVI, maybe 500 with suprainguinal bypass, et cetera. What we really need to do is to tap in to a much larger group of patients, a much larger population. And so we are actually granted access to the data from the Vascular Quality Initiative, and we have actually done that analysis. I can't really show you the results right now because I've submitted for presentation elsewhere, and I won't be able to present it there if we're lucky enough to get that done. So I won't talk about that anymore, but we are specifically looking at predictive models that maybe will help us to be able to kind of compare ahead of time the results of open versus endovascular therapy that is right there at the fingertips for that particular patient that comes into the room. I want to diverge just a little bit to talk about some of the other types, the issues of measuring outcomes. Obviously, we look at survival. We're used to looking at primary, assisted primary, secondary patency as specific outcomes, especially in the vascular surgical world, limb salvage, and perioperative death. Recently, there have been some other things that have been kind of added to, especially from our cardiology colleagues, the concept of target lesion revascularization. If you put some of those things together, you can come up with conglomerates such as amputation-free survival, major adverse limb event. You can even come up with a few others, re-intervention, amputation occlusion, re-intervention, amputation stenosis. All these kind of tell us a little bit about things, but maybe not so much about what's important for the patient. Others have kind of looked at, well, what about their functional status, okay? The outcome of the intervention, are they still functional? Can they live at home? Are they independent or not? And in fact, if you want to get into that even a little bit more, there are measurements of health-related quality of life. Now, one of the problems, though, is when you're looking at things like amputation-free survival and major adverse limb events, that's okay if you're comparing one type of revascularization option to others. But what about the patient with critical limb ischemia who comes in with a gangrenous forefoot, or maybe somebody else with claudication that you're going to treat medically? So if you use those particular things, obviously if you do a primary amputation, well, then it looks like, even though that may be the best thing for the patient, it looks like it's an abject expect failure by using those particular things. On the other hand, if you look at major adverse limb events and you just treat somebody with claudication only with Pletol or Plavix, in fact, you're going to look like you're doing the best of all because you really haven't put that limb at risk. So I think that there's something remaining to be said, something lacking about what's out there. My particular interests have been looking at health-related quality of life. The problem is trying to do those kinds of analyses that really is not only takes a lot of time, but also requires a lot of abstract thinking by the patients. So we actually went that ahead, and we actually, based on previous data, assigned various values according to the treatment and the outcomes of those treatments, and we have been able to come up with perhaps a little bit better way of describing the outcomes of treatment using the so-called calculated quality of life, where now we can also add medical therapy alone and amputation into the mix. Finally, I wanted to talk very briefly about something that's going on. We are just been approved to participate in this trial. We're open for business, and many of you know this. It's the BEST-CLI trial, where the idea is to compare best surgical versus best endovascular therapy for patients who have critical limb ischemia. Is substratified according to whether or not there's a tibial-pedal versus a popliteal target, whether or not the patients have rest pain or tissue loss. And without going into the details, the principal investigators you see here, it is on NIH funding. They have started enrolling. We have yet to enroll our first patient, as we were just approved yesterday, finally, to get through it, but we will. The primary outcome is going to be the major adverse limb event-free survival, a number of secondary clinical outcomes that are of interest, as you can see listed here. Very, very important what they have done also, though, is that they have included quality of life measurements, as you see here. And then finally, they've also addressed costs as well as incremental cost effectiveness. About the only thing that they haven't thrown in is the kitchen sink. I think that comes with the next group of trials. So in any event, that is where we're going. If you have the chance to participate in this, I would encourage you to do so because I think it's going to, at least on the broad basis, answer a number of very important questions. Thank you very much.